Welcome to You and Your Health. I'm your host, Dr. David Bertone. Welcome to our series, our third series of Zoom version of You and Your Health. And our guest today is Dr. Dena Arumugam. Dr. Arumugam is a bariatric surgeon, a weight loss surgeon who specializes in this area. And she's going to talk about various aspects of obesity and bariatric surgery and some of the procedures that are involved and what can be done to improve the health and well-being of people that have been struggling with weight loss that may be morbidly obese, and it's greatly impacting their health and function. So Dr. Arumugam, thank you for joining us and welcome to the show.
Hi, thank you so much for having me. I'm excited to be here.
Great. So give us a little background about how'd you get involved in this type of medicine?
Absolutely. So I trained as a general surgeon. I'm a board certified general surgeon, and general surgeons really operate mainly on the abdomen and organs inside the abdomen. My interest really was in bariatric surgery and minimally invasive surgery, really because I saw how rewarding it was, how thankful patients were, how their lives really truly changed with weight loss surgery. Weight loss surgery is able to really cure and treat a lot of medical conditions, and it's completely rewarding to be able to see that and do that for my patients.
Great. And you're fellowship trained in this area?
That's right. I did a specialty training or fellowship training in bariatric surgery after completing my general surgery training.
Great. And your practice now is Jersey Shore Advanced Surgical Associates, correct?
That's correct. We're located in Neptune, New Jersey, and we operate mainly out of Jersey Shore University Medical Center.
And I know that the procedure that we're going to talk about, the hospital has some advanced standing or some specialty in this area. Can you explain that?
That's right. Yeah, Jersey Shore Medical Center is a bariatric center of excellence. Not all hospitals that perform bariatric surgery have that title. What that really means is that our program, our bariatric surgery program at Jersey Shore, every 3 years it gets evaluated. And what they're looking for are institutions that have high volumes of bariatric surgery with good outcomes. So good outcomes as far as weight loss goes, and also with low rates of complications. And we're very proud to say we've been doing great since the start of our program at Jersey Shore Medical Center, holding that title of Bariatric Center of Excellence.
Awesome. So we're going to talk about the procedure in a little bit, but obviously this starts with obesity and the problems with obesity. And can we just go over as a surgeon and a medical doctor, what are some of the problems associated with people that are morbidly obese?
So we know that obesity is correlated with several medical conditions. We call it the metabolic syndrome. Extra weight, heart disease, diabetes, high blood pressure, high cholesterol. We're finding problems with the lungs like sleep apnea. It's also correlated with things like anxiety and depression, arthritis. Sometimes we see problems with infertility in females as well. So it's really head to toe, it affects our health.
Okay. And these people typically, before they come to you, have tried a lot of things, correct?
Absolutely. Yeah. Surgery is usually a last resort for people. No one likes to jump into an operation unless they really need it. So most people have tried it all. They've tried the dieting, the exercise, combination of things, medications. And for the most part, people can lose some weight trying those things. But it's usually not enough weight really to get them back down to a healthy weight where their medical conditions can improve as well.
Now, is there a typical patient? Is there like a metabolic index or some level of obesity that's usually considered for this type of procedure?
Absolutely, yes. So we use something called the BMI or the body mass index. And that's a calculation that is made based on a person's height and their weight. And that's easy to Google it and find out what your BMI is. And we use a criteria of a BMI. Anyone that has a BMI that's equal to or above 40 automatically would qualify for surgery. Anyone with a BMI equal to or above 35 with at least one medical comorbidity that we typically see being associated with having the extra weight, some of those things I mentioned earlier, then that would qualify you for surgery also. The reason that we use that BMI of 35 is because that's when we start seeing some of those medical conditions becoming more common: diabetes, high blood pressure, high cholesterol. So if we can treat the obesity at that BMI level, we can also treat those medical conditions.
Great. So a patient comes to you for the first time. I'm assuming they're referred from a primary care doctor or some nutritionist or people that have been, even I would imagine psychologists are making some referrals. And so what is a typical workup for these patients when you first see them?
So it starts with an evaluation by one of the surgeons, and we really go through the entire medical history and find out what's going to be pertinent to having a major operation. Everyone does need to see a nutritionist as well as a psychologist prior to surgery. That's actually an insurance requirement.
Okay.
And then just based on the individual's medical history, we have them see other doctors. Sometimes it's just a primary doctor. Sometimes it would be a cardiologist or a pulmonologist, a lung doctor. And that really all just depends on their own medical history.
Okay. Are there any people that are kind of, they're excluded from having this type of procedure? Are there certain conditions or pre-existing problems that you, during your initial evaluation, it's not indicated for them?
Sure. So that mainly is based on the BMI. So if the BMI cutoff, if you don't reach that cutoff, then we wouldn't offer surgery. So we're not going to operate, on everyone just because they're interested in weight loss surgery. We do want to see that BMI cutoff be reached. After that, anyone who has a very sick heart, very sick lungs, that they won't be able to tolerate general anesthesia for the procedure, that might be a reason to not do the operation. Anyone who's actively smoking, we actually ask them to quit smoking prior to surgery as well, because the risk of smoking is very high. It can really increase the risk of complications around the time of surgery by tenfold, actually. So we work with them to be able to help them quit if that's a problem for them also. Okay. Other things, I'm sorry, go ahead.
No, that's okay. I mean, some other factors.
Yeah, other things would be any active drug abuse, alcohol abuse, major psychiatric problem, eating disorder, those kinds of things. We would have those treated first and then talk about surgery later on.
Okay. Is there any specific tests that you order or lab work that you do at that initial consultation?
We do. So we usually order an X-ray test. It's called a swallow study. It gives us a nice outline of the stomach. It tells us if the patient has significant reflux, where acid is refluxing back up into the esophagus from the stomach. It can also tell us if they have a hiatal hernia, where the stomach sits up in the chest a little bit, which is not where it's supposed to be. The other things we sometimes do are have them get an endoscopy, where we look with the camera inside the stomach to check the lining of the stomach, make sure that it's healthy, there's no ulcers, things like that. As far as blood work goes, we usually do that right before surgery. We want to make sure that their hemoglobin levels are normal. We check their vitamin levels. Those are most of the things that we'll be checking right before surgery.
Great. Okay, so you go through all of that and then you start talking to the patient about some of the surgical options, correct? Now I know there's a few different procedures, so I'm going to put up a slide in which we'll show the three common procedures that you might do. So if you can just explain briefly what we're looking at here.
Yeah, sure. So just to broadly categorize the surgeries, they work in different ways. Some surgeries we call restrictive operations. That means that they restrict the amount of food that you can eat at one time, so you feel full very quickly. The other types of surgeries are the ones that are malabsorptive. That means that they change the anatomy in a way that actually prevents you from absorbing all of the calories that you eat. So of the three operations that you just had up, we have the gastric banding, the gastric bypass, and the sleeve gastrectomy. So the gastric banding, which is the one here on the left, that involves putting a plastic material around the upper part of the stomach there. And that serves as, it's an adjustable band. That means that we can make it tighter or looser around the stomach. And that happens by injecting some fluid through a port that sits right underneath the skin. And then that fluid then travels into the band. So you can sort of think of it as like a belt around your waist. You tighten the belt, you feel really full. You could also loosen that belt and then feel less full. So this is a completely restrictive operation. The more tight the belt is, the less that you're able to eat at any one time because you feel very full.
Okay. And the second one?
The second one up there is the gastric bypass. So the gastric bypass operation is what we consider the gold standard operation for weight loss surgery. It's been around for decades. It works really well for weight loss and for improving medical conditions. What we do for the gastric bypass is we actually cut the stomach. We make it about the size of a walnut or so. It can hold about 3 ounces. We then cut the small intestine. The small intestine is where absorption and digestion of nutrients happens. And we make a new connection between the stomach and the small intestine. By doing that, we're actually bypassing a large portion of the stomach and a large portion of the intestine. And that's a malabsorptive surgery. So by bypassing the intestine, the nutrients don't get absorbed in those areas of the intestine. And then, just a simple way of thinking about it is you eat 2,000 calories, but only 1,200 calories get absorbed. So that's where the malabsorption comes in.
Okay. And the third procedure?
The third procedure is called the sleeve gastrectomy, and that's mainly a restrictive operation. What we do here is we actually cut and staple and remove about 70% of the stomach. So we leave a long, skinny piece of stomach intact, and that can hold about 4 ounces or so at a time. And it mainly restricts the amount of food that you eat because you get full very quickly. The upper part of the stomach that we remove actually secretes a hormone that's involved in hunger. So by removing that part of the stomach, we actually decrease the hunger sensation as well. So people actually feel less hungry after the operation as well. And that contributes to weight loss too.
Okay, so obviously there are 3 options, primarily 3 options for you and the patient that you will help the patient in deciding what's best for them, I'm assuming?
That's right. Yeah. So it's really all about a discussion. Some patients come into our office and they say, I know exactly what I want, and they have reasons for it. And that's great. Some patients really don't know. So it's really just a discussion about them, their eating habits, their support system, what they think that they'll be able to accomplish with each operation, their, long-term follow-up and things like that. And you figure out which surgery is best for them.
So I think what we'll do is when we come back after the break, we're going to talk about the different procedures and how you decide which is best for them, and then explain the whole process of going from initial consultation to surgery date, and then what happens after that. So when we come back after the break, we'll pick up the topic, and we'll be right back here on You and Your Health.
COVID-19 is on the rise. It's more important now than ever to follow strict guidelines. Protect yourself and loved ones. Always wear a mask in public. Wash your hands frequently. Maintain a safe distance of at least 6 feet from others, and work with contact tracers. It's also helpful to get your flu shot this year.
Together, we can stop the spread of COVID-19. For more information, visit middlesexcountynj.gov/COVID-19.
The COVID pandemic has forced arts venues across New Jersey to close their doors. We hope this is just an intermission, but your support is needed now more than ever before. Without it, many may never reopen, impacting countless local businesses and communities. The arts in New Jersey drive $662 million to our state's economy. Recovery depends on you. Learn how you can help at keepjerseyartsalive.org.
Hey, let's check out this park. Oh, wow, that's really cool. To find a great local park or forest near you, go to discovertheforest.org.
welcome back to You and Your Health. I'm your host, Dr. David Bertone. Our guest today is Dr. Dena Arumugam, who's a bariatric surgeon at Jersey Shore Advanced Surgical Associates, who's talking to us about the various types of bariatric or weight loss surgeries that are available for people, especially when you have gross obesity that hasn't been able to resolve with nutrition or diet changes and exercise. So Dr. Arumugam, thanks for joining us again and welcome back.
Thank you.
So when we left off before the break, we were talking about the 3 different procedures. And I just want to know a little bit about how do you decide in consultation with the patient which one is best for them?
So just in general, I'll say that the majority of bariatric surgery across the country right now is the sleeve gastrectomy. That's over 65% of all bariatric surgery. And the reason for that is because the sleeve is a very good surgery for weight loss. It's a very good surgery for improving those medical conditions that are typically associated with having the extra weight. And it's a relatively safe operation of the 3. And all the operations, we sort of compare it to the gastric bypass, which is our gold standard operation for weight loss. So as far as the sleeve goes compared to the gastric bypass, it's safer and it's almost as good as the gastric bypass goes as far as weight loss and improvement of those medical conditions. So I would say it's definitely the most common operation we're performing right now. As far as an individual basis and which surgery we decide to do for each patient, a lot of that has to do with the patient preference. Some patients really know exactly what they want. And then the other things we think about are sort of long-term. So the gastric bypass might work a little bit better for patients that have higher BMIs, more weight to lose. And they also might work a little bit better for patients that have very poorly controlled diabetes. And that's in comparison to the other 2 surgeries. It might actually improve the diabetes a little bit better. Mm-hmm. The main concerns with doing the gastric bypass, and the reason we don't do it on everybody, is because of the long-term potential risks and complications that we could see. Those are things like malnutrition. So to some degree, the purpose of the surgery is to prevent your body from absorbing everything that you eat. If that happens to an extreme, then we find that some patients actually have trouble absorbing the important nutrients and vitamins and minerals that they need. And that can make them very sick. The other thing we worry about are things like ulcerations along the connections that we create, intestinal blockages, dumping syndrome, things like that, which really can happen at any point after the gastric bypass, day 1 to 30 years later. Those things we really don't have to worry about after the sleeve gastrectomy. So within a couple weeks after the sleeve, if everything is going well, then the majority of those risks have disappeared essentially. The sleeve works really great for weight loss. It can help you achieve about a 60-65% excess weight loss. The gastric bypass probably somewhere around 70% or so. So like I said, very close, maybe a little bit better for the gastric bypass.
Now, it sounds like the banding is done less. And
that's right, yeah.
When you're explaining it, it sounds like maybe that's the least invasive of the 3?
That's true, yeah. So the gastric banding is the least invasive of the 3. It originated in the early 2000s as an alternative that was considered safer and, like you said, less invasive than the gastric bypass. And it was very popular for a decade or so. But what we're finding more recently is that the band doesn't really work that well for weight loss over 5-10 years down the road. And we're finding that patients are having complications related to it, significant reflux or slippage of the band where the band moves a little bit and can actually obstruct the stomach or block the stomach. So actually, we're really not commonly putting bands in anymore. The reason for that being, again, that we have a good alternative that's safe and effective, which is really the sleeve.
Okay, so it sounds like the sleeve is the best option. It's a little bit more invasive. You're making permanent changes to the stomach Absolutely. And connections. Can any of that be reversed if you had to?
So the band is completely reversible. Yes, we can take it out and you have your normal anatomy there. The sleeve is not reversible, no. So we're taking out a piece of the stomach and we can't give any of that stomach back later on. The stomach probably does have some stretch to it over time, but never goes back to its initial state. The gastric bypass operation, in theory, can be reversed. It's not an easy operation to reverse. So we would do that in rare circumstances when the complications are so severe that, you know, a person really can't go on living with the gastric bypass anatomy.
Okay. So what are some of those potential complications that might develop? What are some of the things that you see that says, okay, we got to do something different?
Sure. So in the short term, the things we look for in the first couple of weeks after surgery are things like bleeding, heart attacks, pulmonary embolism where clots can develop in the lungs, things like that. The other major thing we worry about is something called a leak, where anytime we staple or cut the intestine, if that area doesn't heal properly, then intestinal fluid can leak inside the abdomen, cause a significant infection. Those are all things that we can manage either with surgery or endoscopic techniques, but they can make patients very sick. The good thing is they happen very rarely, 1 to 2% of the time, but unfortunately that number is not zero.
Right. Okay.
Over the long term, the main risk or complication we worry about after the sleeve is something like bad reflux or narrowing of the sleeve, which can cause blockages, which again happens rarely. Long-term complications after the gastric bypass are some of those things I mentioned earlier: intestinal blockages, ulcerations along the stomach connection that we create, malnutrition, low vitamin levels, or dumping syndrome.
Got it. Okay, so a patient comes to you, do the workup, you decide on the surgery. Now the next thing is to figure out, is the insurance going to pay for it? And what's that process like? So can you take us through that?
Yeah, absolutely. So we know really most of the time we can figure out from the get-go whether insurance is going to cover the surgery or not. Unfortunately, not all insurances do cover bariatric surgery still, but our office is very well-versed in figuring these things out. And we talk to the insurance companies all the time to figure out whether we have coverage or not. Once we find out that we do have coverage through insurance, then the process is very different based on which insurance company we're dealing with. Some insurance companies require monthly visits in our office over the course of anywhere from 3 to 6 months, being a part of our weight loss program. And then once a month, we have a visit, we check your weight, we sort of go through the whole process and make sure that we're staying on track. During that time, we have our patients see a nutritionist, see a psychologist, get some of those x-rays and blood work and things that I mentioned earlier, and then see any other consultants that are relevant to that patient's medical history.
Okay, so it sounds like it's a good 4 to 6 month process or more.
I would say, yeah, on average, it's usually at least 4 months or so.
Okay. So then they have the procedure. What is the typical post-op care for these patients, or what can they expect? How long are they in the hospital for?
Sure.
Diet modifications and some precautions. Let's talk about that.
Yeah, so the nice thing is that all of our surgeries these days are done laparoscopically or minimally invasive. That means we use little tiny incisions to do the surgery as opposed to a big incision, which is how they did it 30, 40 years ago. So that really allows our patients to get back up on their feet, move in back to normal life really within just a matter of a few days. It's usually a one-night stay in the hospital, and within 24 hours, most of our patients can go home. And what we're looking for are things like being able to drink some liquids without feeling nauseous, pain being comfortable, being able to get up and walk around, things like that. And once they check those boxes, we can usually get them home.
Okay.
As far as dietary restrictions and things like that after surgery, we do have our patients go on a progressive diet after the surgery. So this is a high protein diet. Starts out as a liquid diet, mainly protein shakes, really because protein is good for healing the body, and the liquids are good to let the stomach have time to heal after a major operation. So they do a liquid diet, then we have them do a week of like a thicker liquid diet, like yogurts, cottage cheese, things like that. And then for the last 2 weeks, they're doing soft food, high in protein, things like eggs and soft fishes and chicken salad and that kind of consistency. So it's really just high protein foods that are lean and that are easy for the stomach to digest while the stomach is healing from surgery.
What about activity restrictions? Are they encouraged to stay active? Are they encouraged to walk, or Any other
Yeah.
basic fitness activities, or is activity limited?
No, we definitely encourage our patients to walk and get up and moving as much as they can after surgery. We don't want them to run a mile or go on a bike immediately, but walking is great. Walking helps reduce the risk of developing blood clots. It helps the lungs, prevent any kind of infection in the lungs from occurring, things like that. So walking is great as soon as surgery is over, really. We usually have them on restricted as far as exercise goes for about 2 weeks after surgery. So we
Okay.
see them in the office at 2 weeks. And at that time point, if everything's going well, we have them start back up on, going on the bike and going on the treadmill or the elliptical and things like that.
Great. What about return to work? Is it an extended period of time out of work, or is it depending on their occupation or lifting restrictions?
Yeah, so I would say usually it's about 2 weeks off from work. And that's mainly just to make sure that they're comfortable, their incisions are healing well, and they think they can manage a full day at work. Restrictions as far as lifting and things go, that's for about a month after surgery, anything over 20 pounds, so that no hernias develop at any of those incisions that we create. So yeah, it's a little bit dependent on the occupation that they have.
Okay. And the follow-up after surgery, how long do they see you? Do they see you for a few months, or is there a yearly follow-up, or how does that work?
So for the first year, we like to see our patients every 3 to 6 months, really just to make sure everything is going well. They're not having any trouble with eating and that their weight loss is right on track. After that first year, we extend it. So once a year is perfect. We love to see our patients for years to come and see how they're doing and, make sure they're not having any problems. So once a year visit is exactly what we would hope for.
Great. What do you see in terms of the future of bariatric surgery? Is there things to look forward to maybe in the next 5 years?
Absolutely. Bariatric surgery is ever changing, really. So the amount of or the types of operations that have evolved over time is really extensive, actually. We're definitely in a nice place right now where we have some good operations that work really well. But I'm sure that's going to keep changing, and we're going to have newer ways to do things, maybe even less invasive ways than we're doing right now. So yeah, I think it's going to keep changing.
Great. Okay, well, I really appreciate you joining us today, Dr. Arumugam. It's been very exciting to learn about bariatric surgery and all the different procedures that are available for people with obesity. So thanks again for taking the time and joining us. And we'll put some information up for people to be able to get in touch with you if they would like to
Great.
schedule a consultation. So thanks again for joining us on You and Your Health. Until next time, I'm Dr. David Bertone. Continued good health.
You made her college years possible, opening that education savings account when she was little, spearheading campus tours, and deciphering financial aid. If you can ace planning for college, you can do it for retirement. Get on track with tips at aceyourretirement.org.
There's a shelter pet who wants to meet you. Meet one today. Visit theshelterpetproject.org. Adopt.